Greetings and welcome to today's webinar on implants, the first of the Family Planning Method Series. My name is Pia Kocher and I am the Knowledge Management Coordinator for the Advancing Partners and Communities Project. Before we begin today's presentations, I'd like to review the Adobe Connect environment and set a few norms for today's webinar. Today's webinar has 3 presentations followed by a discussion period during which our speakers will address your questions. Within the webinar environment, please make use of the Q&A box on the bottom right side of your screen to share your thoughts, note your questions, or ask for help with sound during the presentation. Questions you ask are only visible to you, our presenters, and technical support. If you are experiencing difficulties, our technical support will respond to your question privately. We will collect your questions for our speakers and will save them for the discussion period. It is great that we are able to connect people from so many places today, but your experience may vary based on your internet connection and computer equipment. I will briefly go over a few troubleshooting steps if you have technology challenges today. A few troubleshooting tips. If you lose connectivity or cannot hear, close the webinar. Re-enter the meeting room in a browser other than Google Chrome by clicking on the webinar link provided. Use the Q&A box to ask APC Tech for assistance. If troubleshooting steps are not successful, please rest assured the webinar is being recorded and you will receive an email with a link to the recording following today's event. Questions that don't get answered during the Q&A sessions will be compiled after the webinar, shared with presenters, and responses from presenters will be shared with participants. To get us started, I will now turn it over to our moderator, Elaine Minotti.
I would like to welcome and thank everyone for joining us today. My name is Elaine Minotti, Health Development Officer for USAID. Today's webinar is organized by the Advancing Partners and Communities Project in collaboration with Family Planning 2020, the Implementing Best Practices Initiative, and USAID's Office of Population and Reproductive Health. This webinar on implants is the first in a series of webinars that will highlight a range of family planning methods to deepen our understanding in expanding method choice globally. We are aiming to reach ministries of health, policymakers, donors, and program managers. This series will provide information on family planning methods themselves, country case studies from a range of partners and settings, and highlight family planning service delivery channels. We are aiming to provide technical information and updates on a broad range of family planning methods, engaging a global audience, highlighting programmatic successes and challenges, and help answer questions specific to each method. And while each webinar will highlight a single method, in programs and in practice, we expect that clients have access to a broad range of methods, they receive client-centered counseling, they can freely choose their method, they receive detailed information on the chosen method, and that providers are able to offer and counsel clients on a range of methods. After each presentation, we'll have a quiz to test your knowledge. I will go over the answers at the end of the webinar. Please take a few moments to answer our first question. I would now like to introduce our first speaker, Dr. Abdul Momin Saad of USAID's Office of Population and Reproductive Health. Over to you, Dr. Saad.
Hi, Saad, are you there?
Just wait a few minutes while our presenter gets his audio connected, but we're ready when he is.
Hello, can you hear me?
Yes, we can hear you.
Yes, sorry, I was muted actually. So I'm coming back online. All right, thank you, Ellen, and thank you, Pierre and Tishila, for putting this together and for the logistic support. And thank you for the opportunity to participate in this important webinar. I will be discussing briefly on implants, and we do know that implants were introduced almost 3 decades ago, and they are one of the most effective family planning methods available when used in accordance with approved prescribing information. The Population Council developed the first contraceptive implant called Implant, which was approved in 1983. But I think Implant is no longer available in the market. Next slide, please. The overview will look at what are implants and mechanism of action, including how to use, side effect profile, and medical eligibility criteria, as well as effectiveness and type and differences between implants. And we'll also discuss service delivery requirements and models for service delivery. Next slide. Quickly, implants are hormone-containing thin, flexible 1 to 2 rods, and sometimes capsules, and each about the size of a matchstick. And they are containing the hormone called progestin, and they are inserted under the skin in the arm, and therefore they are not usually visible. And once inserted, implants do not require any action from the client. And the implants are long-lasting, very effective in preventing pregnancy, and they are rapidly reversible, and no delay or in return to fertility once they are removed. And that is why implants are considered to be long-acting, reversible contraceptive method. Although implants are not the only methods in this class, IUDs, including hormonal and copper T IUD, are part of this class, but this webinar will not be discussing IUD, may be discussed in subsequent webinars. And once inserted, they are effective for 3 to 5 years. Quickly looking at the mechanism of action or how implants work, they actually achieve their contraceptive action by thickening cervical mucus, thereby blocking sperm from meeting an egg, and they also suppress ovulation, preventing the release of eggs from the ovaries. The hormone levels required to suppress ovulation are reached within 3 days, and they are effective immediately if inserted during the first 5 to 7 days of menstrual cycle. And they are also effective immediately during immediate postpartum or post-abortion period. Next slide. The currently available implants in the market are 3 products. The first product I will be discussing in this table is Sino Implant, manufactured by Shanghai Dahua Pharmaceuticals, and is available under the global brand name called Plant, as well as other trade names including Implant, Trust, and Zarin. The Plant is a set of 2 flexible cylindrical rods, each containing 75 milligrams of levonorgestrel, known as LNG, and it has a total of 150 LNG in the product. It is WHO pre-qualified for 3 years, but the manufacturers are currently preparing to make a submission to WHO for extended use for up to 2 years. This is not a guarantee because it's at the prerogative of WHO to determine if the data is sufficient to warrant extension for up to 4 years of use. It costs about $7.50 to about $8, and costs a couple years of protection of about $2.50 to $2.67. I will pause a little to talk about CYP, known as Kapolei Protection, which is the estimated protection provided by contraceptive methods during a 1-year period. It's usually based upon the volume of all contraceptives sold or distributed free of charge to clients during the period. It doesn't necessarily estimate actual use or impact, but basically providing information about coverage and also allowing programs to compare their to compare programs across countries or across activities. Next product I will be discussing is Jadal, which is manufactured by Bayer, and it is WHO pre-qualified in 2009 for 5 years duration of use. It has 2 flexible rods similar to Sino implant, and each containing LNG 75 milligram to a total of 150 milligram. It is inserted using a disposable separate trocar, which is the applicator, and the average cost is about $8.50 and $1.70 cost per CYP. Implant on NXT is manufactured by Merck. It's supplied as in a preloaded disposable applicator that makes it much easier for providers to insert one flexible rod which contains 68 milligram of etonogestrel, also known as ETG, under the skin. It costs about $8.50 and $2.80 per CYP. It's important to see the differences in the molecule between the 3 products. Both Levoplant and Jadal contain levonorgestrel, while Implant on NXT contains 68 milligram of etonogestrel as the active ingredient. And it has only 1 rod, while Levoplant and Jadal has 2 rods of 75 milligram each of LNG. And then quickly, just to highlight what WHO pre-qualification is, it is a service provided by WHO to assess the quality and safety as well as efficacy of medicinal products. Originally in 2001, the focus was on medicines for treating HIV/AIDS, tuberculosis, and malaria. But in 2006, this was extended to cover medicines and products for reproductive health, including family planning products. Next slide, please. Implants offer immense potential to meet the need for family planning. Extremely effective contraceptives that release an ultra-low amount of progestin continuously into the bloodstream. Women who use implants find them to be very convenient, acceptable, and highly tolerable. And implants do not interfere with sexual intercourse and return to fertility as discussed earlier. It's not delayed or negatively affected once the implants are removed. And they are suitable for all women to delay space or limit pregnancies, and they are becoming increasingly popular across the world. It is important to mention that implants do not protect against sexually transmitted infections and HIV, and if that is a concern, it is recommended that whoever has an implant as the product of choice should use other methods of prevention, including condom use. Next slide. These are some of the experiences that clients experiences from clients who use implants. At the initial, immediately post-insertion is usually the common symptom that clients present with, insertion site irritation, and very rarely infection at the site of implant can occur, but we hardly see that in practice, but it does occur, but very rarely. And the major side effect associated with the use of implant is a change in bleeding patterns related to the frequency, duration, and amount, which may result in irregular bleeding, spotting, or heavy bleeding, and in some cases, amenorrhea or cessation of the menstrual bleeding completely. And other potential side effects include mild headaches, abdominal pain, nausea, breast tenderness, and mood changes. Next slide. One great advantage of implants is that it can be used by almost all women, ranging from young individuals who have barriers to use of family planning methods to either delay the first birth, or even women who have not given birth and wanted to delay their first birth. And it's also applicable to women who want to space their birth, either after giving birth, that is in the postpartum period, or immediately after an abortion. And it also can be used by women during breastfeeding and women who are HIV positive, and it also can be used to limit birth after desired fertility goals are reached, either in women with high parity or in women with low parity. Next slide. A little about the medical eligibility criteria, which is now on its fifth edition that is released in 2015. And the MEC is evidence-based information and guidance developed by the WHO on the safety of various contraceptive methods for use in the context of specific health condition and characteristics. It contains more than 2,000 recommendations for 25 different methods and addresses more than 80 different medical conditions or patient characteristics. It addresses issues from disease condition to physiological state as breastfeeding or pregnancy, and it utilizes a 48 classification that is stratified by safety for using a contraceptive method given a specific condition. And these categories are 1, 2, 3, and 4. For the first category, all conditions that do not have any restriction on use of the method or any method of contraceptive. And in the second category, it's considered conditions where the advantages of using a method generally outweigh theoretical or proven risks of not using the method. And theoretical, in the third category is when the theoretical or proven risks usually outweigh advantages of using a method. And for category 4, it is unacceptable health risks to use a method. In resource-limited settings where it is really difficult or do not have the infrastructure and the capacity to clearly differentiate conditions into category 1, 2, 3, and 4, the WHO made it easier to collapse the the first and second category into one single block that the method can generally be used. While in category 3 and 4 is collapsed into one single block, but once condition is in category 3 or 4, that the WHO recommends that the method should not be used in those conditions. Next slide. The good news is that implant medical eligibility criteria for use in implants is usually within category 1 and 2. If you look at the colored columns, on column 3 highlighted in yellow, it's where implant belongs. And if you look at most of the conditions are either in category 1 or 3, meaning category 1 or 2, excuse me, then the method could be used, could generally be used. In the boxes, the darker green color indicates category 1, while the lighter green color indicates category 2. But there are some clarifications in some other conditions, but generally the good news is that implant is applicable and could be used generally for many of the medical conditions highlighted in medical eligibility criteria. Except some few disease conditions like serious liver disease, problems with clots or unusual vaginal bleeding, or in women who have had breast cancer. Next slide. Looking at the typical use effectiveness, implants, as I have mentioned earlier, that they are one of the most effective contraceptive methods available, with an annual pregnancy rate less than 1% with all implants. All the three products I have discussed in the previous slide. And continuation rates are often better for long-acting methods, including implants, and those for shorter-acting methods, and no significant difference are found in the contraceptive effectiveness or continuation rate among users of the various three classes or three groups of implants discussed in the previous slide. Next slide. Implants require a suitable service setting that is clean, with adequate infection control, privacy, counseling, and continuity of care. One important aspect of long-acting reversible contraceptives, including implants, it's that it's important that programs are planned very well to ensure that the capacity and well-trained providers and well-motivated providers are there to provide the service, including informed choice, thoughtful counseling to help clients select the method, anticipatory guidance regarding common side effects of implant, especially about bleeding changes, and they are capable and reassuring management of side effects, especially also related to bleeding changes. And regular and reliable access to removal services is very important. When there are no reliable removal services, they may backlash and have a negative consequence to the entire family planning program. And of course, adequate follow-up and referral system where especially women receive implants in a mobile platform or mobile service delivery channel. Next slide. A number of countries have successfully followed innovative service delivery models that entail the use of dedicated providers. These providers focus primarily on delivering underutilized clinical contraceptive methods, including implant. But they also provide a wider range of other methods at this site. And the service models have also typically entailed tax shifting and provision of free services, either free or at public or private sector with a fee or through mobile outreach or voucher system. Establishing adequate referral system, especially for women who receive implants through mobile services or community-based program, is really vital. We can't emphasize this enough. Next slide. I would like to summarize by still stating the fact that implants are very effective, safe, and suitable for nearly all women. With only one action, women who use implants can be almost certain not to have an unintended pregnancy for up to 3 to 5 years. And many cadres of healthcare providers can provide implants safely and effectively. Some of the challenges include quality. Quality is highly essential, and counseling about and management of bleeding side effects are key to helping women use implants successfully in order to reduce discontinuation rate. And service delivery, it may be service delivery intensive, but highly motivated and trained providers are great for insertion and removal because no provider, if there is no provider, there will be no program. And it may have high upfront cost, but the overall cost of implants by CYP is comparable or even less than that of injectable or pills. Thank you very much, and I look forward to responding to your questions.
Thank you, Dr. Saad.
Good morning, good afternoon, good evening, good day, good night, wherever you are. Thanks for the introduction and to Dr. Saad for the excellent overview to contraceptive implants. I think that's a great predecessor to what I'm hoping to talk about, which is addressing some of the global trends in contraceptive implant use, as well as a few programming considerations for implant introduction and scale up that we found particularly relevant and helpful in our family planning work here at JPIGO. So first, let me go through some of the trends. So contraceptive implants are accelerating growth in contraceptive prevalence worldwide. Avenir Health recently conducted an analysis of 256 DHS surveys, and when comparing the distribution of annual rates of MCPR growth between countries with significant uptake of implants and those without it, found that uptake of implants was associated with higher rates of MCPR growth. They also found that the growth of implant use was not coming at the expense of use of other contraceptives. In other words, that implants were not cannibalizing or being substituted in place of other methods. So they also noted actually that with every 1 percentage point in implant use rise, there was an associated 1 percentage point rise in MCPR, implying that the rise in implants is not dominated by modern method users switching methods, but rather a net growth in modern users. So I think really, promising to think about the power that contraceptive implants have in raising, overall MCPR and meeting the needs of women and families around the world. So next, I just want to turn to a few country-specific examples of MCPR and implant growth. So first, I'll start with Kenya. I'm going to give you a quick orientation to the slide itself, because in each of the 3 country examples I'll show, I'll be using the same template. So what you're looking at right now is overall contraceptive prevalence represented in the total height of each bar, with the colored sections within each bar representing the method mix that constitutes that prevalence. So in each case, contraceptive implants will be represented in that pink or purplish color. And I'll leave the y-axis on the same scale so that it's easier to see the relative composition of contraceptive prevalence and method mix across the 3 countries. On the x-axis across the bottom are the DHS and PMA surveys from which this data was pulled and the year they were conducted. So you can see over time how MCPR and implant method mix has shifted. So here in the Kenya example, you can see that MCPR has grown quite impressively over the past few years to over 60% of married women using modern contraception, with implants making up over 25% of the method mix. You can see how that dark pink section really grows over time. Of note, implant use also is relatively high among unmarried women, which are not represented here on the graph, at around 11% of the method mix. So turning to another East African country, here we have Uganda. Uganda has lower contraceptive prevalence overall, but again, you can see that the contraceptive implant proportions are increasing over the past few years. And then in a third context, this time Burkina Faso in West Africa, here we also see recent rises in total contraceptive prevalence, again in the total height of the bar. But the contribution of implants is even more drastic in Burkina Faso, with implants now making up nearly 50% of the method mix among married women. So a really substantial share of contraceptive use coming from contraceptive implants in Burkina. So those were just a few country-specific examples of the contribution that implants make to MCPR growth in some settings, but obviously implant use varies greatly around the world. So where do implants comprise larger proportions of overall contraceptive use? Well, this map shows the proportion of implant users among all married contraceptive users across a number of countries. This would be otherwise known as implants' contribution to the contraceptive method mix. So in the darkest green countries on the map, the contraceptive implants comprise over 15% of total modern contraceptive use. So as you can see, Burkina Faso, Kenya, Uganda are all represented in dark green to reflect the large proportion of contraceptive use attributable to contraceptive implant use, which was mentioned in the previous slides. Looking outside of the African context, you can also see, for example, that Indonesia on the right side of the screen is more of a medium green. They have about an 8% method mix attributable to implants. So just a nice kind of global picture of where implants comprise a larger proportion of contraceptive use. So what's led to the accelerated growth in contraceptive implant use in recent years? Well, for one, in 2012, a price reduction was negotiated with two major contraceptive implant manufacturers, Bayer and Merck MSD, to reduce the cost of implants to $8.50 per unit, down from around $20 or $25 just a few years prior, as you can see here on the slide. This created price parity among the 3 major implant manufacturers, including Shanghai Dawa, whose product Levoplant was already competitively priced. The reduced price of implants allows for larger procurements from countries and donors and improves their accessibility overall. Now, taking a closer look at the users of contraceptive implants, here's some data about how implant users compare to contraceptive users overall. So this data is from special surveys conducted by PMA 2020 in Burkina Faso, Ethiopia, and Kenya. And in these countries, implant users are, on average, more married, higher parity, and less educated than the total population of contraceptive users in those countries. They're also more likely to receive their method in a public facility. So, for example, just looking at Burkina Faso, we see that overall, 85% of contraceptive users are married. But for implant users alone, that figure is 90%. 74% of contraceptive users in Burkina have at least 2 children, while 80% of implant users have at least 2 children. And while 56% of contraceptive users have no education, 64% of implant users have no education. Additionally, from the analysis by Availing Health that I referenced earlier, they explored whether implant use was concentrated in certain age groups and found that no implant use occurs across all age groups globally. However, I'd be remiss not to mention that more exploration is needed to understand a little more how we can improve accessibility to all family planning, including implants, to adolescents and youth. Okay, so now we'll shift gears a little bit into some programming considerations for introducing and scaling up contraceptive implants. Before moving into the considerations themselves, I'd like to make an important point, which I think Elaine mentioned earlier in the webinar as well, but that contraceptive implant programming is rarely done as a standalone effort. Rather, efforts to improve access to contraceptive implants are generally best seated in programming that seeks to improve access to a wide array of contraceptive options so that clients can make an informed choice. I thought I'd first share some lessons learned from a multi-country project led by JPIGA from 2013 to 2016. Under the Bill and Melinda Gates Foundation funded Accelerating Scale-Up of Implants project, JPIGA worked with stakeholders in Kenya, Nigeria, Zambia, and South Africa to capacitate healthcare providers and systems to respond to the growing availability of and demand for contraceptive implants in that context of full method choice. I'll delve a bit deeper into a few of these on the following slides, but overall we learned it was critical to develop implant introduction and scale-up plans, to factor in product evolutions, to consider the needs of implant users not only at initiation, but also for follow-up care and removal, to consider the provision of implants outside of family planning wards, for example, through community-based distribution or in maternity settings for postpartum clients, to avail the necessary equipment and consumables that are required to insert and remove contraceptive implants, and to work with communities and clients to dispel myths and misconceptions. So now, just to highlight a few of these specific lessons, I noted on the last slide that it's important to factor in product evolutions in scale-up planning. And what I mean by that is that programs should understand which implant products they have or will have available in their contraceptive market. So Implanon NXT, for example, is a newer iteration of the classic Implanon product. It utilizes an improved insertion device, or trocar, which operates slightly differently than the earlier version. So introducing Implanon NXT in contexts where providers were familiar with the previous version of Implanon requires refresher courses for healthcare providers. And I think this is an important lesson learned out of some of our work. So the resource noted on the slide here is for a course to quickly and effectively update implant providers on this newer Implanon NXT device through on-the-job training. Dr. Saad, in his overview, also highlighted the recent WHO pre-qualification of Levoplant. Over 200,000 Levoplant have been procured in recent weeks to Sierra Leone, Uganda, and Malawi. And so programs expanding access to Levoplant should ensure that healthcare providers are adequately trained to offer 2-rod implants. Again, noting that the insertion mechanism for a 2-rod implant versus a 1-rod implant is slightly different. And so having providers trained in one and not the other requires that they be updated in both if they're expected to offer both. So the next lesson that I wanted to highlight was that programs should consider the needs of implant users not only at initiation, but for follow-up care and removal as well. Here we have a simple graphic developed by the Implant Removal Task Force, and the graphic demonstrates the conditions that should be in place in order for a client using a contraceptive implant to be assured access to quality implant removal services. So for example, implant clients should know where and when they can get their implant removed, and those services should be available when she wants them and within a reasonable distance. At the time of removal, she should be offered reassurance and counseling, reinsertion, and the option to switch or discontinue a method if she would like. A confident and competent provider should be available, and the supplies and equipment should be in place for the procedure. It's also important to note that the service should probably be affordable or free, and that the data around implant removal should be collected and monitored and used to inform programming in the future. It's critical that any programs that strive to improve access to contraceptive implants also improve access to follow-up care and removal when desired. This is also responsive to the principles of rights-based family planning. So next, when it comes to availing implants immediately after delivery, Dr. Saad noted that women are medically eligible to use contraceptive implants immediately after delivery, even when breastfeeding. This is also shown in the postpartum contraception initiation timing graphic shown here on the slide. With that in mind, programs should consider how maternal care settings, including ANC, intrapartum, and postnatal care, can adequately counsel for and provide implant services. So this may require training additional providers from maternity wards to offer implants and stocking implant commodities and supplies in the labor and delivery ward to facilitate more efficient provision. It may also require strengthening internal facility referral mechanisms so that women can pass by the family planning ward during their childbirth stay. The final lesson learned that I'll address during today's webinar is the need to avail necessary equipment and consumables to insert and remove contraceptive implants. It's not enough to ensure that the implants themselves make their way down to facility stockroom shelves. Contraceptive implant insertion and removal require a few basic instruments and consumables to be carried out safely and with quality. On the slide here are all of the required equipment and consumables necessary for implant insertion and removal. Of note, the forceps are only needed for removal. So we have job aids like the one from which these illustrations were pulled and other materials to support LARC capacity building, and those can be found in the new Providing LARCs Learning Resource Package available on K4Health. One final thing before I hand this back over to Elaine, I just wanted to quickly address a final programming consideration that might be on the horizon, which is a possible change in the approved duration of use for the one rod contraceptive implant product, Implanon. Study findings published in 2016 and 2017 demonstrated that the 3-year Implanon product can actually provide contraceptive protection for up to 5 years, rather than the 3 that it's labeled for. So I know we're really eager to hear if guidance will be issued on this duration change and hope that you'll also stay tuned for more information on this. Certainly a change in duration would require communication to providers and clients alike. Of note, Dr. Saad also noted that levoplants labeling under WHO prequalification is also likely to shift from 3 years to 4 years duration of use.
Thank you, Megan. Please continue adding your questions for Megan in the Q&A box. And next, take a few moments to answer our next quiz question. The next presentation is from George Akanlu of Mary Stopes International, Ghana. Over to you, George.
Hi, good afternoon, good morning to everybody. I hope you can all hear.
We can hear you, George.
Okay, so I just want to start by saying thank you to the organizers for making me a part of this webinar, and also to the 2 previous presenters for laying the background. I'll start by giving you some context of the Ghana program. So if you look at Ghana, we have limited access to the full range of family planning services. And this is more prominent in the rural areas because there are limited skilled personnel for the provision of long-acting and reversible family planning methods. There are also gaps sometimes in commodity availability as the facility facility level, not because the commodities are not available, but because there's a problem with the supply chain management, that there are instances where the commodities are stuck either at the regional level or at the district level and not getting to the facilities where they are needed. And family planning is still not free in Ghana, and therefore cost is still a barrier. So if you look at uptake of family planning generally, there's similar proportion of contraception in rural and urban areas, but there's huge variation regionally. This is here the DHS, but if you look at LAC specifically, there's a variation between uptake in rural areas and in urban areas. And if you look at the service mix, LAC and PMs constitute just about 20% of the total uptake in Ghana. And for implants, they are the preferred LAC, and Jadal is the most preferred implant. For us in Maristoke specifically, we provide family planning services to our clients through different channels. So we currently have 9 centers of excellence, which set the standards for service delivery in our country program. And these centers are strategically located, and we ensure that the right atmosphere is created in these centers so that our clients feel at ease and comfortable. We also have a network of Bluestar Facilities. These are a network of trained and quality assured private providers who provide voluntary family planning services across the country. These 130 facilities are located in various cities and urban areas across the country. We also have a network of Maristoke ladies. These are individual midwives, nurses, or community health workers who are self-employed providers who are trained by Maristoke and certified to provide voluntary family planning services in their community. We have the mobile team. We have 8 mobile clinical outreach and in-reach teams, and then 2 public sector strengthening teams. The outreach teams focus mainly in rural and hard-to-reach areas, taking voluntary family planning services to the doorsteps of our clients. The in-reach teams focus mainly on certain target groups or urban slums where access to voluntary family planning services is limited. Now, the 2 public sector strengthening teams focus more on building capacity for the provision of long-acting and permanent family planning methods in the public sector. So they take public sector workers through the whole range of information, sharing, service provision, and quality assurance. We also have a call center which is dedicated to providing services and referrals to our clients. So for the static sites, we have GPSs of all these static sites sitting with workers in the call center, such that any client who calls the call center in any part of the country and wants family planning services can be directed to any of the static clinics or Bluestar facilities where they can access care. So underpinning all this is clinical quality. And just as the previous presenters mentioned, Maristoke ensures that we recruit, train, and competently assess all the providers who work in all these service delivery channels. So providers are assessed, and whether they are competent or not, they are taken through the process where they become proficient and competent in providing the services. We also ensure that all these providers have access to the clinical guidelines. guidelines by the local Ministry of Health, and international guidelines within which they provide services. We have a clinical quality team in-house that visits these service delivery channels on quarterly basis to provide support to them. In addition to that, we have annual internal and external quality assurance audits. Internal, which means we get somebody in another Maristopes country who comes in to quality assure our services. And then external, we get somebody who is external to Maristopes to come in and quality assure the services that we provide through this service delivery channel. And when gaps are identified, service providers are taken through training, the necessary equipment are provided so that they are able to provide high quality services to our clients. We also ensure that incidences are reported and managed through our system within the Maristopes organization. So we have a system where when an incident happens in any of these service delivery channels, the team is put together, they do the management, they investigate, they share the results among the other service delivery channels as learning so that mistakes that are committed in certain channels are not repeated in others. So looking at implant programming generally, Maristopes Ghana controls almost 17% of the voluntary family planning market in Ghana. And for LAPM, long-acting and permanent methods, we control nearly half. And Jadal and Implanon are the most common family planning implants that we have in Ghana. Up until 2015, implant services were only provided by a midwife. But thanks to some work that has been done by Maristopes Ghana, the Ministry of Health and other partners, the Ghana Health Service has now approved that trained and certified community health nurses can now provide implants. And Maristopes plays a key role in training these community health nurses and certifying them so they can provide implant services. Just some of the key things that we do in reaching out to our clients. So I look at this, grouping our service delivery channels into two, looking at the static side and the mobile side. And for the static side, family planning awareness raising activities are carried out, basically using certified client videos, community debates. Community debates is a gathering of opinion leaders and community members and service providers, where the service providers take the opportunity to provide information and education to community members on voluntary family planning methods. We also work with the Ghana Health Service, where promoters within the Ghana Health Service work with our community-based volunteers to do door-to-door consultations, do door-to-door discussions with clients, and where there's the need for referral, they are referred to the service delivery channels for services. We also have what we call the cross-referral system, because if you look at the network of our Bluestar facilities, 130 of them, not all of them provide the full range of family planning services. So for instance, most of the implant services are provided across all these facilities. But if you look at the other LAPMs like vasectomies and the rest, are not the topic for discussion here, are not services that are provided across all these facilities. So where a client comes in and wants some of these services that are not provided by any of these facilities, they refer to others within the network where the service is available. And again, as I indicated, we have a call center which offers an anonymous platform for client engagement and referral. And we usually have very good branding in our static facilities, the Bluestar facilities and our clinics. For the mobile team, we work basically through the public sector. So our outreach teams and the capacity building teams work through the public sector, So in any district where they go to provide services, they work with providers within the public sector. And we use community mobilizers who work in the public sector to go into the communities and mobilize clients for our outreach teams before the day of the service provision. For the MS ladies, they are stationed in the communities where they stay, and therefore they interact with the communities, and people voluntarily come to them for family planning services. And appealing all this is the quality assurance monitoring that we do on quarterly basis and then on annual basis. And in new communities where our outreach and in-reach teams visit, they also sometimes use targeted mass media campaigns.
Hi, George. Are you still there?
Hello?
Hi, George. You're back on.
Yeah, sorry, I went off air.
It's okay.
So I was just trying to explain the uptake of the family planning methods across all the channels. As you can see, implants constitute a greater part of the service mix, and the uptake of implant services have been growing year by year from 2011 right to 2016. The data for 2017 is as at August this year. And as you can see, we are projecting that we'll be able to provide provide implant services more than we did last year. So we can see a progressive increase in the uptake of implant services right from 2011. My previous presenters also talked about removals. So this is also the rate of removals across all these channels. And as you can see, it's highest among the static side, and especially in our centers. But that has been dropping right from 2014. And I must emphasize that most of these removals are Jadal removals. And the commonest reason usually given is the changes in menstrual cycle. There are few instances where family members or people who are ready to have children also come in for removal. But most people cite changes in menstrual cycle as the main reason for the removal. In terms of our clients and provider insight, I might mention that we have a very robust system for getting our clients and provider insights for our static sites, for our centers and Bluestar Facilities. We do for the mobile teams, but not as rigorous as we do for the static sites. So for our clients, implant insertion is less invasive and they prefer it compared to IUD. They say that there's no or less pain in implant insertion. And Jadal is the most preferred because it offers them longer years of protection. And most of our clients are happy for going to our mobile sites to access implant services because it's for free compared to going to any of the public facilities or static sites. For our providers, they prefer Implanon because it's easy to insert as a result of it having a single rod. Providers also indicate that they are more proficient in implant insertion compared to IUD. And then more providers are trained in implant insertion compared to IUD, for instance, because as I indicated earlier, we now have nurse aides and community health nurses who can be trained to provide implants. Specifically to our program here, generally there's low uptake of LAC in Ghana. And this affects implants also. And the key reason usually it's about the misconception. So for instance, there's a huge misconception out there that implants causes infertility, causes fibroids because of the changes in menstrual cycles and so on and so forth. And there's a lot of work going on in the community to dispel some of these misconceptions and myths. And also, voluntary family planning services are not included in our National Health Insurance System benefits package, which means that people who walk into static sites would have to pay for family planning services. And this, again, is a barrier to uptake of family planning, especially for implants. For us, we think that the rate of removals is quite high, especially in our centers. Some work is currently ongoing to understand, even though we from the client's inside, some reasons have been given for the removals, but some scientific work currently ongoing together with FHI to find out exactly why there's such high removal in some of our service delivery channels. So this is what I wanted to share with you in brief with regards to implant programming in Maristobes, Ghana. Thank you very much. I'll take any questions that come up.
Thank you, George. To our audience, please take a moment to answer questions. Our final quiz question, and we'll go over the answers and move quickly to a few questions in our remaining few minutes. Great, very quickly. So in the introductory presentation, we asked, in a quality family planning program, we expect that clients receive client-centered counseling on a range of methods, and they can freely choose their method without coercion. Our next presentation, Megan spoke about introduction of implants into country programs has caused a decrease in the use of other contraceptive methods. True or false?
And I mean, I think just quickly, Ethiopia probably comes to mind as the place where that's been done at the largest scale and most successfully, though countries like Nigeria are also doing community-based provision of implants through their health extension worker cadre. I think some of the keys to success, and a lot of this has been led under a Pathfinder bilateral in Ethiopia, but is around, really deliberate training and intentional strategic introduction of implants in that context. So requiring, lots of training and a lot of quality checks to make sure that it's done safely. I would just make a note, though, that I think one of the really important things when we consider community-based distribution of implants is just thinking about, what does that mean for removal, like I mentioned earlier. So, if those are provided at the community level, how does that woman then get it removed? Does she go to the facility? Does she somehow queue up that health extension worker to come back to her? What does that look like? So
And George, would you like to add in? I know Ghana has worked with community health nurses, which are not extension workers like in Nigeria or Ethiopia, but a community-based provider did you want to speak to Ghana's experience?
So in Ghana, the community health nurses are usually located in the lowest level of service delivery. So they are usually situated in the CHIPS compounds, which are smaller single-room facilities at the community level. And at that level, they are allowed to provide implants. They work very closely with the community workers at that level. The community workers go into the community to do mobilization, to do education, and then where people want services, they are referred then to go to the CHIPS compound where the services are provided to them. I think that's just the linkage between the community health nurses and the community workers at the community level.
Thank you, George. We have time for one more question, and I will direct it to Dr. Saad. This question is from Jeremiah Yem. Is there any medical explanation to women on implants that tend to lose weight? And as a second part of that question, he asks, is there any reason why levoplant coverage is 3 years, considering the fact that it has the same composition and strength of levonorgestrel with Jadal? Dr. Saad? You may be on mute.
Yeah, I was mute. Quickly on the weight and implant use, I think there is no evidence for LNG, substantial evidence for both implants, the LNG and the ETG for obesity and reduced effectiveness of the method according to medical eligibility criteria. Both methods are still medical eligibility criteria 1. But there are some data that showed weight and reduced effectiveness of implants following like 4-year use, but that has not been reflected in the medical eligibility criteria as of now. For the pre-qualification for 3 years, I think it's based on the data submitted to WHO and the clinical data from the manufacturers that warrant pre-qualification, but they are currently having new data that may extend the use of the product for 4 years and potentially 5 years in the near future.
Thank you, Dr. Saad. So it's time to wrap up, and we will answer the remaining questions that came in through the Q&A box, and we'll share those after the fact. We would like to thank all of the presenters for giving their time and expertise today and all of the participants for joining us. In the next few days, you'll be receiving an email